Good afternoon, everyone, and welcome to the latest presentation in the National Telehealth Resource Center's webinar series. These webinars are designed to provide timely information and demonstration to support and guide the development of your telehealth programs. These webinars are presented on the third Thursday of each month. Next slide. Throughout the country, there are 12 regional telehealth resource centers and 2 national telehealth resource centers. Each of them serves as a focal point for advancing the effective use of telehealth and supporting access to telehealth services in rural and underserved communities. Next slide. A few tips before we get started. Your audio has been muted. Please use the Q&A function of Zoom platform to ask your questions. Questions will be answered at the end of the presentation. Today's webinar is being recorded, and you will be able to access it and past webinars on the National TRC YouTube channel. Next slide. Today's webinar is hosted by the Southwest Telehealth Resource Center and presented by Don Graf. I'm Elizabeth Krupinski. I'm the co-director of the Southwest Telehealth Resource Center. Don Graf is a nationally recognized subject matter expert on telehealth. He has passionately supported telehealth expansion and reimbursement reform initiatives in Arizona and on the national stage for nearly 20 years. Don served on the American Medical Association Telehealth Coding Task Force and National Quality Forum, the Telehealth Quality Framework Committee, and was recently inducted into the American Telemedicine Association College of Fellows. He is an agency member of the Arizona Telemedicine Council, a member of the New Mexico Telehealth Alliance. He served as the National Telehealth Director for United Healthcare and currently provides telehealth consulting for provider, health system, and payer community clients across the country. It is my pleasure now to introduce Don. Please welcome him.
I'll help if I unmute. Welcome and thank you everybody for joining today. I wanted to present in the first slide some objectives of what we hope to accomplish during the next few minutes together. And I couldn't help thinking as putting this together how difficult it's going to be to really go through a lot of the ins and outs of reimbursement, especially in the Medicaid arena. And thought that this would be a good opportunity to talk a little bit about the impact that this really has and kind of who has skin in the game. And so on the provider side, the risks and opportunities that exist are really pretty straightforward. You're either going to get paid for the services that you provide or denied for not being allowed. Those are probably the most straightforward. Where things get really sort of difficult and rather expensive is when you get paid for something and then find that it was not paid correctly, and there's recoups that take place and money that gets re-exchanged, or in the case of a denial, having to rebill. All of these things take a lot of money and really impact the provider communities. I don't want to leave out the payers because in that same space, and specifically with respect to the Medicaid populations, for every claim that an insurance company is going to pay a provider, they're going to turn right around and encounter that information upstream to the Medicaid regulators, where they're in essence re-adjudicated. And if for whatever reason don't pass edits and through the regulators, could find the payer actually being sanctioned for an inappropriate payment until that payment is recouped. So there's a lot of sort of length and breadth to all of the ins and outs of effective reimbursement and maximizing income. And today, probably more than ever, it really is impacting because I don't know if people were reading the news feeds this week, but there was a recent Inspector General audit that was conducted of was something short of 200,000 Medicare claims. And it was discovered that upwards of 30% of those claims were actually adjudicated inappropriately. And this is, I think, a real wake-up call to the payer community, to the policymakers, and certainly to Medicare, that we are not all all out of the woods when it comes to getting a good, clean understanding of what we can bill for and how we're going to get paid for the work that's being done. So I'm going to do my best to kind of hit on a number of different things, but there's so many different places where we could do deep dives, and unfortunately, during the time we have together, we'll only be able to glance the surface on some of these. So hopefully we'll be able to get to all the points. This was just a placeholder bio slide that really just says what has already been mentioned, but I do want to speak a little bit, if I could, to some of my background and specifically the work that I'd done in the past doing claims adjudication. I ran a claims adjudication shop for about 10 years. We processed hundreds of thousands of claims. And it was during that time that I really got a keen appreciation for the work that has to go into creating the programming to auto-adjudicate rules and regulations that apply to correct coding initiatives, contract requirements, and to make sure that as claims are coming in, they're being adjudicated and paid appropriately. This is certainly no small feat on just regular claims payment processes. When you start getting into multiple payer communities where we've got public sector, private sector, Medicare, Medicaid, VA, each with their own set of rules and regulations, and each of those sets of regulations changing at just an incredible rate, keeping up with all that programming is no small feat. And so I just wanted to kind of layer that in as kind of a complexity model, and to suggest simply that this whole discussion and subject is certainly anything but a one-size-fits-all kind of scenario. So I know that the talk is really kind of about more of the discussions around Medicaid and Medicare. I do want to just take a minute to talk about commercial or the private payer community, because I think it's important to understand that most of the rules and regulations around payment and reimbursement for telehealth services among that community are going to be managed by the individual contracts that the commercial plans have with the people and the lives that they're covered. Now, obviously, when there are parity legislations and statutes on the books that suggest otherwise, then there's that sort of conflict that might exist between what the laws are and what people are actually able to contract. That's somewhat different than in the Medicaid, Medicare space, where there's just no shortage of rules and regulations and governances about what can be done, who can do it, where they can do it, that layer into the occasion. And when we're considering who has the skin in the game, obviously it's the clinicians providing the services, the health systems, the hospitals who are providing additional services as well. The payer community has got skin in the game because of those sanctions that I talked about and the upstream reporting requirements that many of them have with Medicaid and Medicare regulators. This is an opportunity, I think, to talk a little bit about some of the rules that exist and how they kind of categorize them. In looking at the type of services that exist that are sort of categorized, I'm going to describe them simply in three different telehealth categories. There's a live, synchronous, exchange between video audio exchange between a provider and a patient, simulating as close as possible an in-person telehealth encounter. The second type is an asynchronous connection between patients and providers, where providers are reviewing data, medical information, and providing diagnosis and treatment recommendations for patients without them necessarily being in the same room at the same time. And then, you know, the other is things like remote patient monitoring, where it's not direct service, it's not diagnostics, it's really more chronic disease management. We have the place of service, and I'm going to just kind of put that as a placeholder because we're going to talk about that a little bit longer. But I think that the key takeaway here is to really understand that when there's a telehealth service delivery model in place, the patient obviously is going to be at one location and the provider is going to be at another location. So the question is, well, where is the place of service? There's different schools of thought on that. For the purposes of our discussion, the place of service historically has been the location where the patient resides. The provider is still providing the services, but he's bringing the services to the patient at their location. And that location could be, you know, in another doctor's office. It could be in a hospital, emergency room, clinic. It could be in their home, depending on what's allowed. The other is the allowed procedures, and this could be procedure codes themselves, but in many instances, especially in Medicaid states, this is defined not only by the procedure codes, but also by the subspecialties providers who are delivering those services. So in one state, it may be okay for audiologists to deliver speech-language pathology services, bill for and receive reimbursement for them. In other states, if not explicitly listed, speech pathologists would be unable to bill for those services. So defined by procedure, defined by specialties, it's you know, that's an important thing to take into consideration. One example of the rules, and I put down established relationships. We'll talk a little bit more about new and established patient visits in a minute, but I think that this is a placeholder really to make sure that we talk as much as possible and really understand the concept of a telemedicine visit is, you know, by definition, replicating an in-person visit as much as possible. And like any time you go to see the doctor, you're going to see a doctor that you've either seen and are being treated by, so you're an established patient, or you're seeing someone, you know, for the first time. Obviously, as you're seeing, for a physician you're seeing for the first time, you know, there's more involved in trying to better understand, you know, your case, your role, before decisions are going to be made about your treatment. So let's talk a little bit more about public sector governance. We talked a little bit before about statutory or the parity laws. More and more states every single year are passing parity legislation, which has, for the most part, are being put into place that, trying to think of the best way to describe sort of the spirit of parity legislation would be to say that if a provider believes that they can deliver the same quality of service to a patient using telehealth service delivery model as they could with that patient in person in their office, then they ought to be paid the same for those services. And not just that the doctor believes it, but they document it and they bill it and use the appropriate codes and so forth. And that is sort of the spirit behind statutory parity laws around the country. In most instances, unless specifically stipulated in the statute, those are going to be predominantly rules and regulations governing the commercial payer markets. In many cases, Medicaid, Medicare, and VA rules and regulations that exist in parity states, again, unless otherwise stipulated, are going to follow their own rules. So the Medicare, Medicaid, VA will trump the parity legislation, and it's not good or bad. It's just different, and continues to have represent itself as sort of another level of complexity in the discussion. The third, and not by no means last, are rules and regulations as dictated by medical boards in the communities that exist around the country. And it's important to understand that medical boards making a decision, for example, as was the case in Texas, I believe. The medical board said, if you want to be a licensed to deliver medical services in the state of Texas, and you want to use telehealth delivery model, you have to have had a established relationship with that patient. And so when you consider certain forms of telehealth where it might be entirely appropriate for telehealth services to be delivered by a provider to a new patient, the medical board in that community would not allow it. So in that case, it's going to trump any regulation. It's going to trump, pretty much, everything. So there's that interdependency and in some cases hierarchical impact that exists and has to be taken into consideration. This is something that is very dynamic space. Medical boards in individual states are now forming compacts where, from a credentialing standpoint, just they're coming together in groups of states, and so we're hoping that a lot of the hierarchy and the impact associated with that will be mitigated over time. But there are still rules out there that all have to be taken into consideration. And in the case of so going back to regulatory for just a second, specifically in the Medicare space, the rules and regulations that we see them governing Medicare are changing. Some might consider the pace somewhat glacial, but changing nonetheless. Big changes in store for this year, and we hope to see more regulations being relaxed in the upcoming years. But the key here is that these are sort of broad-based across all Medicare recipients and providers. And unlike Medicaid, which has state-specific regulations, that's where the fun really becomes just a barrel of laughs. And I think I'm going to use just a real brief example to describe what that might look like. And it actually came to me in the form of a question that prior to today's event, and it had to do with the code 99091. It's a remote patient monitoring code recently unbundled by Medicare, and the question was in essence, when's Medicaid going to get on board with doing the same thing? And so I took a look into different Medicaid rules and regulations around the country, and it was kind of interesting. There were actually 3 states that categorically allow. There are 4 states that categorically disallow. There are 20 states that allow the remote patient monitoring and the code, but do it with provisions or stipulations. Remote patient monitoring can only be for congestive heart failure, or congestive heart failure and COPD, or diabetes, or has to be done collaboratively with Area on Aging, Agency on Aging. There's just no end to the nuances of the stipulations under which the code can be used. And then there's 23 states, and this is the one that we really need to pay the most attention to, where there's just simply no reference to remote patient monitoring, that code, in policy for anybody to kind of sink your teeth into. And so, you know, the piece in the title of the discussion, Ask Permission or Beg Forgiveness, this is a perfect example of that. So when you want to do remote patient monitoring for Medicaid patients in a state where there's just simply no rule saying you can or cannot, you know, you really need to do your homework up front to make sure that you're going to get paid for the work that's being done. So this is where the fun becomes, and we're going to stay light here, but I think it's important that I give those of you that, and I know we've got several master coders in the room, and I apologize, you know, in advance, but this is foundational stuff, and I think it's going to be, you know, important. So let's talk about the CPT procedure codes. There's a whole book of CPT procedure codes that describe every kind of procedure, you know, you can possibly think of. And for the purposes of our discussion, we're going to be talking about the evaluation and management codes. There's 5 for each new patient and 5 for established patient. These are that's one way, as we mentioned before, how you can determine whether I'm billing for a visit with an established patient or a new patient. Each of those 5 new and 5 established patient codes have rules and regulations and criteria in which you know, things have to be performed. So, for example, in each new and established E&M code, there is a key component of the history of the patient, the examination of the patient, and the complexity associated with the medical decision-making for that patient. For each of those key components, the level of complexity, time, will dictate whether it's a 1, 2, 3, 4, or 5, and the more, you know, the more complex, the more the reimbursement. So that's just the code itself. I'm going to jump over to the modifier section and tell you that for not every code, but for many codes that are out there, there is the opportunity to add a 2-digit alphanumeric field to the end of that code that will further describe what kind of services that's being performed. Historically, the GT and GQ code have been put on the end of an E&M code to describe that the services that were being delivered are done using telehealth service delivery model. I'll just tell you sort of as an aside that every time you go see your PCP and in many times general internist doctors, it's these E&M codes that they'll be using and billing for. So that's you know, that's one important thing to remember. I think the other thing that's really key here is that whatever code the physician chooses to put down on the bill that they're submitting for reimbursement, it is important that the level of complexity associated with that bill is replicated in the chart note that the physician dictates, because on retrospective review or examination, that's the very thing that they're going to look at to see what the doctor charted is the same as what they billed, and if so, then, you know, everything is okay. There has been some recent changes in the use of a modifier, and we're going to talk just briefly about that, because the modifier 95 is now being used by Medicare for services being provided to delineate them as being telehealth services. We just really don't have time to go into the detail and the rationale behind their choice to substitute GT for 95, but or 95 for GT, but it suffice it to say that is sort of the landscape that we live in today. And while I kind of personally believe it was sort of throwing the baby out with the bathwater, would suggest to you that it's just not the modifier, but Medicare also has selected that in a different place on the claim where you can put down the place of service, they're suggesting that use an O2 modifier to delineate the services being provided as telehealth. There's I know this might sound complicated, but when we start talking about the place of service and the type of service that are being put onto a particular claim, this is really important because when we look at all the rules and regulations that are around for telehealth services, you can do the programming and do the correct coding initiative programming for any field that appears on the claim itself. So the place of service, so the claim, the code itself, the modifier itself. But there are many other instances where there's lots of rules and regulations that exist where unfortunately there is no place on the claim to be able to identify and dictate your compliance with the rule in that particular category. And we're going to talk about that in just a minute. But I didn't want to leave this slide without talking just briefly about other kinds of codes that are out there. There are HCPCS codes, and I'll use one as an example, the Q3014. It's a facility fee that's specific to telehealth. And in this case, it's the code that's used by a facility that's the location where the patient is presenting from, the originating site, and the ability for them in some instances to get reimbursed for the technical services that they're providing by presenting that patient. So they're not delivering pro-fee services or professional services. It's more of a technical component to those services. And Medicare does reimburse for the Q3014 for facilities that are presenting patients. And on the Medicaid side, it's hit and miss. There are some states that allow reimbursement for facility fee, others that do not. The last code, this S9110 that I wanted to mention, is really just an example of a code for remote patient monitoring that was introduced by Medicare, I think it was 3 years ago, as a way to describe and capture the services that are being provided in remote patient monitoring and chronic disease management. So the delivery, the setup of the equipment, the monitoring of the data, and decisions that are made around the services that are provided under remote monitoring. Maybe it's ironic, maybe it's, I don't know what the adjective best to describe it, but Medicare created the code and the definition for the code, but no reimbursement for the code, suggesting that, that you let just sort of the payer community figure out what might be an appropriate way to pay for it. So we've got another dynamic going on where codes are being developed, but there's no mechanism for payment of the code. It's really just a description of it. We already talked about the different types of services, so I won't belabor that. So let's talk a little bit more about those non-coding rules that exist out there. There are there's in Medicaid. I'm chuckling a little bit because you almost have to in order to not go crazy when you look at some of the rules in Medicaid about that you couldn't possibly program into an auto adjudication system or figure out a way to get it on a bill when it says that in order for a telehealth encounter to be reimbursable, the patient has to live more than 20 miles away from the provider, or the patient has to live in a community of less than 50,000 people. These are rules and regulations that are abound across all the states and have been in place in some cases for many, many years, and are slowly being simplified in some measure because of some of the reforms going on at Medicare, but a very, very slow process. So, when we go back to the sort of the theme of the topic again, the sort of beg forgiveness or ask permission, you stand in front of a rule like that, you can't sort of auto adjudicate to that rule. How do you know what to do in a situation like that? You really are going to have to do a lot of due diligence, and as was suggested as an outcome from the Inspector General audit, is that you really need to do your homework up front before deciding on the kinds of telehealth services that you want to provide in your particular community, especially if it's among the Medicaid populations, and make sure that that everybody is all on the same page with respect to that. So we'll talk a little bit more about that in just a minute. The place of service confusion that exists, and in my example with Medicare earlier, exacerbated by their decision to use the O2 for the place of service to say that this was telehealth. I mentioned earlier that the originating site, or the site where the patient resides, and the distant site, or the location where the provider resides, are the two distinguishing places. And historically, the originating site was the location where the place of service was delineated. So let's say, for example, there's a rule that says that in order for a telehealth encounter or claim to be reimbursed, the patient must be present at a hospital, a clinic, another doctor's office, an emergency room, cannot specifically be in their home. Well, when you have a place of service on your claim and you say home in a telehealth encounter, I can't remember what number home is, but when you use the number for home, you're going into the system with that number, and hopefully the rules are set up to allow that in instances where the home is actually allowed, and that you wouldn't use home or provide those services to somebody in their home if Medicare and Medicaid specifically said that you could not. And oh, by the way, Medicare today, with some exceptions, is not allowing home as the originating site, but that is changing very rapidly. If it hasn't already. Let's see. I want to talk a little bit about the geographical requirements because this is another area where it's really important that to understand that the rules and regulations around driven by Medicare have historically identified the use of telemedicine service model primarily for patients who lived in rural, underserved communities. And so for a long time, there was a rule that said, if you're a patient wanting to get services delivered through telehealth, you better be living in one of these urban centers, rural or frontier settings, communities, and not in a downtown urban setting, because it wouldn't and shouldn't be covered unless like I said, it's either rural or health provider service shortage area. The OIG audit that we talked about earlier, and the 30% of the claims that were identified as being adjudicated inappropriately, cited the originating site and the rural designation as the two key areas that were wrong. And while the rules are changing, rules that are in place governing those are dictated by the date of service. So if the date of service was during a time when you couldn't have home as an originating site, then it's very likely that all those claims that got paid, I think it's $3.7 million, I can't remember the exact number, will be recouped. And, when you think about the way Medicare and in some cases Medicaid recoup, it's anything but clean. You'll submit a claim that's a clean claim, but instead of getting paid for that claim, let's say it was $100, you'd get a note back from Medicare and Medicaid saying, well, it's a clean claim. We're going to pay the $100, but we're not going to give you the $100. We're going to recoup a claim you submitted 6 months ago that was not correct on retrospective review, and we're going to take and sort of not pay you for this one to recoup for that one. And so the back end receivables and all the coding and things that you need to do to fix this claim against that claim is anything but fun. While we're talking about rules and these kinds of ways of interpreting them, let me just give you an example of something that many big national providers are doing specific with Medicaid and Medicare regulations. So we'll say that national payer has Medicaid contracts in virtually all the states. The policies and the correct coding initiative that they're going to lay down typically as a groundwork is going to be sort of the Medicare policy, which in many instances mimics Medicaid, and that's where you start getting into these policy exceptions. They will then go in and start adding, Arizona has a policy exception that says this, that, or whatever. And so they layer that in. So claims coming in specific to Arizona get pinged against a certain subset of rules having to do with that. And in many cases, when you look at the rule exceptions to policies, they're many, many, many times more extensive than the rule itself because of the policy changes that are going on within the specific state and environment. And let me try and put that into perspective a little bit. I think it was last year, 17, we were tracking somewhere in the neighborhood of 284 separate pieces of telehealth legislation, most of it Medicaid, all of it telehealth, and all of it changing, fortunately, in a positive direction. But in every one of those instances, those rules were impacting the adjudication of claims, and so all that programming, all that decisions on how to pay comes from a very dynamic space. So how do you maneuver through all these waters? It's where is the source of truth to this dynamic and changing environment? And I'm gonna start for Center for Connected Healthcare Policy and the American Telemedicine Association have done a stellar job putting together periodicals that try as best as possible to really sort of outline what is out there, what's allowed, what's not allowed, and I know many people use them as the source of truth for deciding what and when they're going to do telehealth. There's a couple of limitations that I think are important, sort of to not put all of our eggs in one basket when doing our due diligence. And the first of which is the frequency in which the resources are updated is not real time. It's certainly not as real time as the legislation and all these rules or changes that are going on. And so it's important that we make sure that we've got the most accurate, up-to-date information. I think it's also really important to understand the documents themselves, the American Telemedicine Association and CCHP's documents, and be really crystal clear on the categories that they choose. So one point as an example would be, I'll pick on the ATA just because I love them so much. Let's say the ATA's periodical says that this particular aspect of telehealth is allowed. point of fact is that if you go into the actual rule, there may not be reference to it at all, or they may be vague reference to it, but not anything specific enough to really sort of sink your teeth in and be sure that you're going to actually get paid. So this is an example of where there's no reference or limited reference to something. Choosing to categorize it as allowed is sort of that, ask permission, beg forgiveness, or so there is some of that to take into consideration. The other piece I think is going to be important is really to look at the due diligence and ask what are the steps that we need to go through to make sure that we're getting paid appropriately. And one is to actually work with the payer community, with state regulators. They are acutely interested in making sure that everybody's on the same page. Certainly the regulators and the payers want to be on the same page because the payers don't want to be sanctioned. Providers want to be on the same page with the payers because they want to be paid. And so working with your payer to test the codes to make sure in advance that the correct coding criteria that you're using is appropriate. The other, I think, is to understand that even in the best of testing environments or the best interpretation, that in those instances where the rules and regulations and testing them can only be done through retrospective review, that chart notes are being conducted for telehealth encounters that clearly identify them as telehealth, and as clear as possible identify things like place of service, type of service, and all the things that just typically go into chart notes. I know this has been a tremendous amount of information, and I struggle a little bit because there's just so many areas where we could dive a lot deeper. But let me just kind of conclude by saying that this is all about a front end load, and doing the due diligence up front is the best policy for making sure that the reimbursement that you're getting is appropriate, adequate, and timely, and you're reducing the instances and likelihood of having sanctions or payments being recouped or claims being denied. If there's any questions at all that come after this that we're not able to get to, please feel free to reach out to me. I'd be more than happy to get together with anybody to talk more about and do a deeper dive into the topic that we're discussing today. So at this point, this is the Q&A. I'll turn it back over for questions.
Excellent. Well, we have about 13 questions. So we're going to try to get through as many as we can, but if not, as Don said, that he does, he will respond to your emails, and we should be able to get a record of these. So let's just start at the first ones and then work our way through. Any information specific to rural health clinics versus FFS would be helpful. I think this was back when you were talking about remote monitoring.
Right. So I'm going to ask you to ask the question again, because I want to make sure I got it.
Do you have any information specific to rural health clinics versus FFS?
FFS. So let me talk about rural clinics, for example, because when we talk about like FQHCs, for example, they have their own sort of set of rules and regulations about telehealth that are today somewhat confining. There's 4 wall rules that would allow an FQHC to be an originating site but not a distant site. So when we have FQHCs that might have multiple facilities throughout a state, and want to provide services between one clinic and a satellite clinic versus a main clinic. What they can bill for and not bill for can be somewhat problematic, especially when we talk about that facility fee. So here's a quick example. If a FQHC says, "Oh, we're going to do telemedicine, and I'm going to room a patient who's going to present to one of our other physicians in one of our other locations," that physician at that other location can bill for their professional fee, but the facility where the patient presented from cannot bill for that Q3014 code. And so the question that the originating site practice manager would say is, well, why would I want to fill it with a patient presenting that I can't get reimbursed for? I'm going to fill it with a patient who's seeing a provider in person and generate the money for that. So there are specific rules around rural clinics that are different than others.
Okay, thank you. Back when you were talking about the 99091, what are the states and the stipulations?
Say the last part again. I'm sorry.
The states and the stipulations.
Yeah.
For the 99091.
Yeah, that's a mouthful. When especially in the Medicaid space, each state, as I mentioned in the recap, there was a few that sort of categorically allowed, a few that categorically disallowed. There was 20 or so that that allowed it, but allowed it with comment that added further delineation in terms of what would be allowed: certain medical conditions, certain lengths of time, certain frequency of billing. The new unbundled allows for a monthly billing. In Texas, I think 99090 or 91 is a daily billing, and so the rates are different. But it's just all over the place. And then the one that's probably the most impacting are the 20 or so states that just don't speak to it at all, and not just the code, but actually allowing the service. They might say, well, we endorse it, we engage and support the spirit of it, but there's no fee structure for reimbursement.
Is there some place where it lists the individual states and what they do, or no?
Well, the two resources, the CHPs and ATA resources, are two that try and keep up as best as possible to those changing environments.
Great. Could you please give a reference to substituting or using the 95 modifier for the GT modifier? Is there a reference specifically where they could find out about that?
Yeah, CMS website, and just all you have to do is type in Telehealth 95 or Place of Service 02, and you'll get all sorts of hits on the recent rule change by Medicare and what's required. And it's all driven by Medicare's relative value reimbursement model. It's rather complex. I understand the spirit of what they were doing. I don't think it was thought through completely, but there's lots of literature and many opinions other than just mine on the subject.
Here's an easy one. Is 95 actually replacing GT, or is GT still being used?
In Medicare, it's replacing GT, except in Medicare states, Alaska and Hawaii, I think. You have to go in and look at their rules, but they even have their own exception to the 95. But in most instances, in the commercial space and in the Medicaid space, the GT modifier is still the predominant modifier used for synchronous telehealth encounter.
Great. Okay. Do you happen to know the timeline for CMS at the federal level and state levels, Medicaid, to change the restrictive requirements around delivering telemedicine? For example, the rural designation or health professional shortage area.
Well, if you're keeping up with the news feeds and seeing the recent changes that are going through with Medicare, specific to rural designation, specific to originating site, it's moving at a pace today quicker than it's moved in the last 10 years from Medicare's perspective. Medicaid follows and will come along, but every state is different. Some regions are different, and so it's going to be a few years before Medicaid is going to across the country unilaterally is going to catch up, especially in some conservative states.
Okay, kind of two related questions, so I'm going to combine them. When does Medicare cover telemedicine into the home? And are patient homes or other sites like work and school expressly forbidden by CMS for qualifying as an originating site? Are provider homes expressly forbidden as qualifying as distant sites? So basically, what are the regulations around the home, and is anything expressly forbidden?
Right. And well, okay, so just to be clear, the home would be the home where the patient is presenting from, is the originating site. And historically, and even today, there are many Medicaid states and Medicare regulations historically that specifically precluded the home as the originating site. So to be absolutely accurate, Medicaid and Medicare in many cases list allowable originating site locations, and it's the doctor's office, the other emergency room, the hospital. There are more and more states, Medicaid states, that have adopted those CMS list of originating sites, but are adding, individual states are adding, and the home, and school-based clinic, and and so they're adding the exceptions, and in some cases, they actually eliminate the list altogether and say if the provider believes, as in the case of parity, that they can deliver the same quality of service, then there shouldn't be a list, at all, because it is ultimately up to the provider to determine. And I think it's important to understand that even though there may be a rule that says you can provide this service to a patient in their home, at the end of the day, it's up to the doctor, because if the doctor has 3 people in the room, all of the same have the same diagnosis, all of the can be allowed to have services delivered to them in their home, may choose that patient 1 or patient 2 is going to be an appropriate candidate, but wouldn't dream of doing it for patient 3 because of compliance, psychosocial. I mean, it could be a number of different reasons. Ultimately, it's up to the provider. So today, there are specific rules that say you cannot use the home, and in Medicare, state specific, and in many others, and in Medicaid, rapidly changing, if it hasn't already, the originating site allowing the home. And it is changing rapidly.
Sort of related as well. Can a provider deliver a no-charge encounter via telemedicine to a non-qualifying site without penalty from CMS? For example, delivering free emergency medicine visits directly to the Medicaid patient's home because they want to avoid, emergency department utilization that's unnecessary. Well,
and I don't know that I'm going to be the definitive answer on this, but I certainly have an opinion, and it's simple. I've not run into any Medicaid regulator that would ever say we're going to stop you from delivering quality services to your patients. You may not be able to bill for it or receive reimbursement for it, but none of them, will specifically penalize for it. In fact, there's been many instances, some initiatives I've actually been a part of, where we would specifically work with the regulator, provide services with a clear understanding that we wouldn't be billing for them, but we would be sharing the data and the outcome from the benefits of those services, and help support policy reform in that community. And have done so successfully.
And I guess another related question, and the answer would essentially be the same. What are the ramifications for cash-only visits? So if it's cash-only, everybody's okay with it?
Yeah.
I would think so. Cash is cash. Okay. Are you aware if they're able to bill for group visits, such as nutritional and lifestyle medicine education, using telemedicine?
So this is a really important question, and it's not important because of the specifics about the group, but here's the essence of the answer. When you think about the rules and the codes, the rules around the codes that are used to deliver services today, it are the same rules that exist for services that are delivered using telehealth connectivity. So if there are rules today that say that you can bill for group visits and what modifiers and what codes and how much time and all that for a group visit, if you simply substitute a synchronous connection with a provider as opposed to that provider being in the room at the same time, the rules themselves don't change, and that's what needs to be dictated. That would need to be submitted. And that's what's going to pass the parity test. It's going to pass the all the tests for payment.
Okay, well, clearly we're approaching the hour here, and there's a whole bunch more questions. So obviously this is a very important and popular topic, and people are very inquisitive. So people could contact Don by his email address. Do you want to go back one slide and put that up again? So there's his email address, dgraf, Graf 81 at yahoo.com. So please address your questions there. Plus, we'll have them online, and I think you could possibly answer them afterwards through the system, but I'm not sure. So please do try to contact Don by his email. And Don, if you could move up 2 slides. There we go. So thank you everyone for attending the meeting. This presentation has been part of the National Telehealth Resource Center's webinar series. The next webinar is scheduled for the 3rd week in May on Thursday, May 17th. It'll be telebehavioral health models and strategies for rural hospitals and clinics. Jonathan Neufeld from the GP track will be presenting at that one, so please join us then. And next slide. We truly value your opinion on these talks, and we'd like you to take a few minutes to complete an online survey. The link is there. It's a SurveyMonkey. It doesn't take that long to fill out. So again, let's thank Don for a great and very interesting and informative talk, and we will see everybody in a month at the next national webinar. Thank you very much.
Don, thank you. It's very good.